Hello, my name is Jenny Keller. I'm a family nurse practitioner graduate student at the College of Nursing and Health Profession at Arkansas State University. I would like to acknowledge my faculty mentors, Dr. Chris Jordan, Clinical Advisor, and Tammy Bell, Clinical Instructor. This is my Create AState presentation on an examination of alcohol screening within a family practice setting. I'm going to begin with some alarming statistical data. The use of excessive alcohol is the third leading preventable death in the United States, according to the CDC. It is the leading cause of premature mortality, accounting for 1 in 10 deaths among working age adults in the United States. It is the fifth leading risk factor for premature death and disability in 2010. The cost of alcohol misuse carried a U.S. economic burden of approximately $249 billion in 2010. Some definitions I'd like to review. Unhealthy alcohol use defines a spectrum of behaviors to include risky drinking, alcohol use disorder, harmful alcohol use, abuse, or dependence. Alcohol use disorder attributed to 3.3 million deaths globally in 2010, with over 200 associated conditions, including chronic illnesses such as cardiomyopathy, hypertension, hepatitis, pancreatitis, stroke, esophageal varices, and gastritis. Some other alcohol-related acute deaths include motor vehicle accidents, drownings, child maltreatment, homicide, suicide, firearm-related fires, and poisonings. In 2001 alone, there were an estimated 2.3 million years of potential life lost due to excessive use of alcohol. To break down on a visual pie chart, government spending was accounted for $100.7 billion. Binge drinking, $191 billion. Underage drinking, $24.3 billion. And drinking during pregnancy, $5.5 billion. The United States Preventative Task Force recommends screening for unhealthy alcohol use in primary care settings in adults 18 years or older. This is now the standard for family providers. The purpose of this study is to identify the percentage rate of alcohol screening performed in adults 18 years or older in a family practice clinic in Northeast Arkansas. The population, after the IRB was accepted through Arkansas State University and a letter of approval was received from the clinical director. The clinic electronic medical record program randomly selected 50 charts. A non-research retrospective chart review was performed. The patient's social history was reviewed in each file to determine if the alcohol use screening question was documented yes or no. Inclusion criteria was established patient at the multi-provider clinic. Age 18 years of age or older, male or female. The exclusion was under the age of 18 years of age. This clinic received an A+ because the results found that 94% of the charts reviewed had been screened for the use of alcohol. The United States Preventative Task Force has found adequate evidence that screening and providing brief intervention and referral to treatment has found to reduce alcohol consumption by an average of 17%. Some vital influences of this project include increasing knowledge, awareness, and importance of alcohol screening in the primary care setting to improve patient health care outcomes and decrease mortality rates. Globally, there's limited studies performed regarding the use of this. With the guidance and assistance of government agencies, public health and healthcare providers, a significant impact of the detrimental effects of alcohol misuse can be made. This concludes my presentation.